Bismillahirrahmanirrahim. Assalamu alaikum, dear students. Welcome on online teaching system of University of South Asia. I, Dr. Ambreen, is here to teach you people pharmacology and therapeutic one. In this lecture, I'm going to tell you about the sympathomimetic drugs in week 7. So the learning objective of our today's lecture are what do you have understanding of sympathomimetic drugs or sympathetic system, the basic neurotransmitter of sympathetic system. Then we will discuss about the working, their adrenergic drugs, their pharmacological actions, their uses, the divorce effect, and all about the adrenergic drugs that are actually being used commonly. First of all, what is adrenergic system? The prime function of adrenergic system or sympathetic system is to help the human beings to adjust to stress and prepare the body for fight and flight reactions. So what happens is when you are exposed to stress, when any other person is exposed to stress, the heart rate, stroke volume is going to increase and resultant increase in the cardiac output is going to occur. The blood is actually shifted from the skin, gut, kidney, glands to heart, skeletal muscles, brain, and lungs, as these organs need more oxygen for during stress. Pupils and bronchi are dilated. Respiratory system actually is more enhanced or is more working just because in sympathetic system the lungs or heart need more oxygen. The other thing is there is increased fatigue. Blood glucose is also increased by the process of glycogenolysis. The point is, what is glycogenolysis? Lysis is something breakdown of glycogen. So what is going to happen is whenever there would be lysis or breakdown of glycogen, it means you can say that the blood glucose level is going to increase. So in sympathetic system, the blood glucose is going to increase in the stressful conditions. The main neurotransmitter of parasympathetic or sympathetic system is noradrenaline, dopamine, and third one is adrenaline that is majorly secreted by adrenal medulla. As we previously studied, parasympathetic system and the major neurotransmitter in parasympathetic system was acetylcholine. So now we'll discuss about noradrenaline, dopamine, and adrenaline. Now comes the biosynthesis of catecholamines. Catecholamines basically derive from a compound named as tyrosine. Tyrosine converted dopa into dopamine, and noradrenaline and adrenaline. There are certain enzymes that act on every step like tyrosine hydroxylase, dopa decarboxylase, dopamine hydroxylase, PNMT. PNMT stands for phenyl and methyl transferase. The next is the synthesis, the storage, the release, and then the metabolism of noradrenaline and other neurotransmitters. What happens is when they are going to store in the vesicles, so whenever the action potential comes or message comes to them, what is going to happen is these neurotransmitters are going to exit or through a process of agocytosis, and they're going to fuse with the presynaptic membrane, and they are going to come in the synaptic cleft. When they come in the synaptic cleft, they have to reach to the postsynaptic membrane, and mostly the 80% of the neurotransmitter goes back towards the presynaptic terminal. So what happens is the 80% of the neurotransmitter that goes back to the presynaptic terminal are going to face an enzyme named as monoamine oxidase. Monoamine oxidase is abbreviated as MAO. That is an enzyme that actually degrades these neurotransmitters that comes back to the presynaptic terminals and tries to decrease its concentration. And the molecules or the neurotransmitter that actually bypass this MAO are again going to store in the vesicle, and they are again going to be utilized. Now the remaining 20% that are present in the synaptic cleft has to face two things. One is they are going to face COMT. COMT is an enzyme named as catechol O-methyl transferase. What this catechol O-methyl transferase is going to do is exactly like cholinesterase enzyme in the parasympathetic system. As we study, cholinesterase is an enzyme that degrades the parasympathetic system neurotransmitter mean acetylcholine. Meanwhile, COMT is an enzyme that degrades these neurotransmitters in the synaptic cleft, and the molecules that are going on neurotransmitter, and some of them are going to attach to the receptors that are present on the postsynaptic membrane. These receptors are actually very important. They are of different types like alpha, beta, and we are going to further classify it alpha 1, alpha 2, beta 1, beta 2, and beta 3. Mainly, the main difference that lies between alpha 1, alpha 2, beta 1, beta 2, beta 3 is they are not always located everywhere. I mean, they all are not present at the same time. Alpha 1 is present at certain locations in our body. Alpha 2 is present somewhere else. Alpha 3 is present. Beta 1 is present somewhere else. Beta 2, beta 3. They all vary on the locations, and further on their actions. So what is going to happen right now is Alpha 1 is present in the vascular smooth muscles. It is present on the GIT. It is present on the genitourinary smooth muscle sphincters. It is present on the liver. So what is going to happen when adrenaline acts on these alpha 1 receptors? When adrenaline acts, or even adrenergic agonist going to act on the vascular smooth muscle, is going to promote the vasoconstriction. So whenever a vessel is going to constrict, what is going to happen is there will be increase in the blood pressure. Fine. So whenever there is a vasoconstriction, there would be increase in the blood pressure. So here there is a vasoconstriction due to alpha-mediated action of the adrenaline. So here there would be vasoconstriction, and this vasoconstriction occurs mostly in the vessels that lies in the skin and cutaneous membranes and the mucous membrane. Next one is GIT, gastrointestinal tract. So what is going to happen is when adrenaline attaches to the receptors present on the GIT, it is going to relax the smooth muscles of the GIT. So it may decrease the GIT motility and may lead towards the constipation. The next is genitourinary smooth muscle sphincters. As we all know, bladder consists of retrosal muscles, and the trigeminal sphincter is present at the end of this bladder. So what is going to happen is these alpha 1 receptors are present on the trigeminal sphincter that lies at the end of the bladder. So whenever there will be adrenaline, it will cause contraction of this sphincter. This sphincter is going to hold the urine for more longer time. It is going to prevent the urine voiding. Further, we'll discuss about the receptors that are present on these walls of the bladder. I'll tell you soon. The next is alpha 1 are also present on the liver. On the liver, they are going to promote the glycogenolysis. As we earlier discussed, glycogenolysis means lysis of the glycogen. You are going to increase the blood glucose level by this way. The next is alpha 2. Alpha 2 receptors are present on 3 main sites in a body, like pancreatic beta cells. Here they decrease the insulin release. Whenever there is insulin decrease, as we know, insulin is a endocrine hormone that actually maintains our blood sugar level or decreases the blood sugar level. So when there is absence of insulin or decreased level of insulin, the glucose level is going to be increased. So the blood glucose level is going to increase by 2 main points. Number 1 was to the process of glycogenolysis. Number 2 is due to the decrease of the insulin to alpha 2 mediated action. The second point about alpha 2 is alpha 2 are present on the platelet. On the platelets, they promote the platelet aggregation. They are also present on the nerve terminals. They decreases the known adrenaline release here. The next are the beta 1 receptors, my favorite receptors. They are purely present on the heart. So always remember, beta 1 are only present on the heart, or you can say heart only have beta 1 receptor. So when adrenaline or adrenergic agonists are going to stimulate these beta 1 receptors, mean they are going to increase the force of contraction. So whenever the force of contraction of the heart is going to increase, you mean to say the heart rate is actually going to increase. So when the heart rate is going to increase, the cardiac output or all the other actions that the heart is going to perform is ultimately going to increase. The next is beta 2 receptor. Beta 2 receptors are almost present all over the smooth muscles like vascular, bronchial, gastrointestinal tract, genitourinary tract. So in all these areas where the beta 2 are receptors present, they are going to promote the relaxation. When the lungs are going to relax, the bronchia are going to cause bronchodilation. These are very good for the asthmatic patient. Then when you say the vessels are going to relax, means you are going to say vessels are going to vasodilate. And thirdly, when you say GIT is going to relax, you are going to say the GIT is going to decrease the GIT motility. Number 4, when you're going to say genitourinary tract, the retrosal muscles where there are present alpha 2 receptors, what is going to happen is when the alpha 2 receptors are going to promote the relaxation of the bladder, they are going to hold the urine for more longer time. Further, we said there are alpha 1 receptors that are present on the sphincter. Beta 2 are present here. They are going to relax. They are going to contract. They are ultimately going to prevent the urine voiding. Number 3 are beta 3 receptors. They are present on the adipocytes, and here they promote a lipolysis. Lysis is breakdown of lipids. We may revise all these receptors: alpha 1, alpha 2, beta 1, beta 2, and beta 3. Alpha 1 present on the vessels, GIT, sphincters of the bladder, liver. Alpha 2 is present on platelets, pancreas, and nerve terminals. Beta 1 is purely present in the heart. Beta 2 is present on the vascular smooth muscles, GIT, and bronchial smooth muscles. Beta 3 is present on the adipocytes. Now we come towards the adrenergic drugs. Adrenergic drugs mean the drugs that mimic their actions, those that works like the adrenergic or sympathetic stimulation. Like we have few classification. Like first classification is the chemical classification based on the presence and absence of catechol rings. Presence and absence of the catechol rings, we said those who have catechol rings are said to be catecholamines, and those who have absence of the catechol ring is called them non-catecholamine. So we can name few catecholamines like noradrenaline, adrenaline, dopamine, isoprenaline. Non-catecholamines include ephedrine, amphetamine. I'm again going to revise these names. Catecholamines are noradrenaline, adrenaline, dopamine, and isoprenaline. Non-catecholamines are ephedrine, amphetamine. Then we have another classification based on the mode of action, those that act directly on the sympathetic system, those that act indirectly on the sympathetic system by releasing the non-adrenaline release at nerve terminals, or both that have mixed action indirectly or directly. So they act directly. They are almost catecholamines: non-adrenaline, adrenaline, isoprenaline, and dopamine. Indirectly acting are amphetamine, tyramine, and the third one mixed are ephedrine and methoxamine. Then we have another third one classification that is on therapeutic action or clinical classification with the name of vasopressor, cardiac stimulus. Vasopressor are vasoconstrictor that promotes the vasoconstriction like noradrenaline, dopamine, methoxamine, metaraminol. Cardiac stimulants are those that purely act on the beta-1 receptors on the heart like adrenaline, dopamine, isoprenaline, and dibutamine. Then third one is CNS stimulus. CNS stimulus mean these drugs have a tendency, few of them are having tendency that they can cross the blood-brain barrier, so they can stimulate the CNS, like amphetamine and ephedrine. The next comes to bronchodilators. As we said, there are beta-2 receptors present on the lung. They promote the bronchodilation. So salbutamol, dobutamine are the beta-2 agonists. Nasal decongestants, ephedrine, phenylephrine, and nasal decongestants. Appetite suppressants. These sympathomimetic drugs have a very beautiful relationship, interesting relationship with this appetite center. This suppresses the appetite. So these are very good in the patients of obesity. Uterine relaxant, they relaxes the uterus. Salbutamol, terbutaline, and salmeterol have these actions. Now coming towards the actions of the adrenergic system. We've earlier studied about the introduction of the sympathetic system, about the neurotransmitters, about the receptors located. Now we are going to discuss what adrenaline is going to do when it acts on the different segments or different systems in our body, like when it affects on the CVS, smooth muscles, eye, what are the metabolic effects, and what are the skeletal muscles actions. So when it comes about CVS, we discuss about the heart. The blood vessels are obviously about the blood pressure and other vascular blood. Heart. On heart, there are only one beta receptor. So adrenaline is a powerful cardiac stimulant. This is very good thing about adrenaline, that adrenaline is a powerful cardiac stimulant. It acts through the beta-1 receptor. It increases the heart rate. So when the heart rate is going to increase, obviously there would be the increased force of contraction, cardiac output, increase the conduction velocity, work done, and result in oxygen consumption. Then comes towards the blood vessels. This is a very interesting relationship. As we said, there are alpha-1 receptors and beta-2 receptors. Alpha-1 receptors are present on the smooth muscles of the vessels that are present in the skin and mucous membrane. Beta-2 are present on the smooth muscles of the vessels that lie in the skeletal muscles. So what is going to happen is, on alpha-1, there is vasoconstriction, so there is increase in the blood pressure. On the beta-2, there is vasodilation, so there would be decrease in the blood pressure. So ultimately, there is a biphasic response on the blood pressure. Initially, it's seen that there is increase in the blood pressure. Later on, the dominating long-lasting effect is decrease in the blood pressure. Initial increase is due to alpha-1 mediated vasoconstriction, and later on decrease is due to beta-2 vasodilatation. And this response was actually demonstrated by Sir Henry Daly, who demonstrated when alpha receptors blocked with alpha blocking agents, adrenaline produced only a fall in the blood pressure, and he named this response Dallas vasomotor or Dallas phenomenon. This was all about adrenaline. Now we'll discuss about non-adrenaline, that is mainly or purely somehow alpha agonist, and so it brings a rise in the blood pressure. Then comes the other vascular blood. Adrenaline causes the renal vasoconstriction, resulting in the fall in the blood pressure. It causes the pulmonary mesenteric vasoconstriction. It also enhances the blood flow of the cerebral and coronary vessels. valves. Now, the bronchi. Bronchi are obviously present in the lungs, and there are beta 2 receptors present in the lungs. So, what is going to happen is the adrenaline or all these adrenergic drugs are going to cause a bronchodilation. So, they're very, very good in the patients of asthma. Then, on the uterus, the action of adrenaline on non pregnant uterus is it promotes the contraction, while on the last month of the uterus, it promotes the relaxation. GID. On GID, there are alpha 1 and beta 2 receptors, and both are going to cause the relaxation. But the effect of adrenaline or the affinity of the adrenaline with the receptors of the GID is very less. So, what they are going to cause is they are going to cause a weakened transient action. Then comes the splenic capsule. It contracts and results in increase or release of the RBCs in the circulation. And this is a new effect to the pilomotor muscles of the hair follicles. Adrenaline, when acts on the alpha 1 receptor, it promotes the contractions of the pilomotor muscles of the hair follicles. Bladder. Bladder is a very interesting, we earlier discussed, and we said there are beta 2 receptors present on the walls of the detrusor muscles of the bladder, and that there are alpha 1 receptors that are present in trigeminal sphincter, and these muscles are going to relax, and this is going to contract. So what is going to happen is they both are going in combination, and they are going to prevent the outflow of the urine from the bladder. So they are going to promote urinary retention. These drugs or these adrenaline agonists are very good for the patients who are having nocturnal and diuresis, or in the children that do bedwetting. Then comes about eye. As we earlier studied about eye in parasympathomimetics and parasympathetolytics, now we are going to discuss about eye and sympathomimetics. Adrenaline causes the mydriasis due to the contraction of the radial muscles of the iris through alpha 1 receptor. It also reduces the intraocular pressure. Mydriasis is contraction of the radial muscle of the iris, while along with mydriasis here there is a decrease in the intraocular pressure to alpha mediated receptors. So what happens is glaucoma can be due to two reasons: due to the increased synthesis of the aqueous fluid, or due to the decreased drainage of aqueous fluid from the eye. So if the cases are due to the increased synthesis of the aqueous fluid, we may use adrenergic drugs to decrease the production of aqueous liquid by cellular bodies of the eye and also by uvosacral outflow. There are beta 2 receptors that are present on the ciliary muscles and promotes the relaxation of the ciliary muscles. Then there are some metabolic effects that comes under the sympathetic system, that they increase the blood sugar level by glycogenolysis. They also inhibit the insulin through the process of alpha 2 mediated action, and they also act on the beta 2 receptors in the adipocytes and increases the breakdown of triglycerides. So we have studied about CVS, we have studied about the blood vessels, the blood pressure, the vascular breast, the lungs, the GIT, the bladder, the pilomotor muscles, and the detrusor muscles, and metabolic effects. And then we have also discussed about the eye. The last one is contra muscles. Adrenergic drugs also facilitate the neuromuscular transmission by the action of both alpha and beta receptors. They have few adverse effects like anxiety, palpitation, weakness, tremors, pallid, dizziness, restlessness, and especially the throbbing headache. Now we are going to discuss about the uses of adrenaline or adrenaline-related drugs. It is being used in anaphylactic shock. It is being used in cardiac arrest. It is also being used in acute bronchial asthma. It is also being used for the control of hemorrhage. It is used with local anesthetic and glaucoma. So we will discuss each point individually. So how adrenaline is helpful in anaphylactic shock is considered to be drug of choice in anaphylactic shock. It immediately reverses the dizziness, hypertension, laryngeal edema, and the bronchospasm. Adrenaline is actually considered life-saving in the patients of anaphylactic shock. Cardiac arrest. Adrenaline is considered to good for the patient who has sudden cardiac arrest due to drowning or electric shocks are treated with intracardiac adrenaline. Asthma, beta 2 receptors are present on the lungs. So what is going to happen is adrenaline is going to attach to the beta 2 receptors and going to cause bronchodilation. So in the patients of asthma, there is bronchoconstriction. So they are going to help us in the patients of bronchial asthma. The next is control of hemorrhage. As we said, there are alpha 1 receptors that are present on the blood vessels of the skin and mucous membrane. So if there would be bleeding and the blood is going to lose, what is going to happen is if adrenaline is being used for this purpose, it is going to cause the vasoconstriction and it is going to prevent the bleeding. The next, with local anesthetic. Injections with lignocaine, adrenaline produces the vasoconstriction and reduces the rate of absorption of the local anesthetic, and thus prolongs the duration of action of local anesthetic. Glaucoma. Glaucoma is increased intraocular pressure. Adrenaline has a tendency to decrease intraocular pressure, so it is considered to helpful in the patient with glaucoma. The next step we are going to discuss is about non-adrenaline. This was all about adrenaline. Now we are going to discuss about non-adrenaline. Non-adrenaline is a mainly alpha agonist, can be used in short to increase the BP, but it is rarely used. The next is isoprenaline. Isoprenaline is a synthetic catecholamine. It is a cardiac stimulant, muscle relaxant properties. Due to vasodilation, it is considered a potent vasodilator. Isoprenaline is very good for the patients of the heart attack and heart block and the bronchial asthma. The next one is dopamine. Dopamine has a different action on the basis of the dosage, like low doses it acts on the D1 receptors and high doses it acts on the beta 1 receptors stimulated. And for the high doses it affects alpha 1 receptors and activates them and causes a vasoconstriction increase in the blood pressure. Then we have diphenhydramine. Diphenhydramine is a relatively selective beta-1 agonist. When I say beta-1, you come to understand we are going to discuss about heart, because beta-1 are only present on heart. Though it also activates the alpha receptor, but in therapeutic doses. The only prominent action of this is they increase the force of contraction of the heart without significant other effect. The next come is amphetamine and ephedrine. They are non-catecholamines. They can cross the CNS, the blood-brain barrier, so they both are CNS stimulants. They act. Now, this is slightly different from the previous one. Ephedrine and amphetamines, they act directly stimulates alpha and beta receptors and directly to the release of non-adrenaline. So they have a dual sort of action. Repeated administration at short intervals result in tachyphylaxis. Ephedrine increases the blood pressure by peripheral vasoconstriction and by increasing the cardiac output. Adverse effects are sleeplessness, tremors, and difficulty in micturition. Difficulty in micturition is due to, he said, the beta-2 relaxation and the alpha-2 contraction. They are both going to prevent. So if a person is using ephedrine for some purpose, the person may experience difficulty in micturition and urine voiding. The uses of ephedrine. Bronchial asthma, nasal decongestion. Bronchial asthma because it is beta-2 agonist. Nasal decongestion because it causes the alpha-1 vessels to vasoconstrict. Mydriasis and hypertension. Narcolepsy, who tends to sleep more. It causes the CNS stimulation and causes sleep decrease in the sleep level. Nocturnal and enuresis, nighttime bedwetting. We use these to prevent the urinary outflow. The next is amphetamine. So whenever amphetamine comes, you may think about coffee or something about caffeine, because amphetamine belongs to the class of caffeine. So they have a almost similar effects like caffeine. So when in exams you tend to take coffee just in order to be alert and increase your mental and physical activity. If you actually want to increase the concentration and your attention span, so you used to drink tea or coffee. Similarly, amphetamine has exactly like somehow same effect like coffee. It is a potent CNS stimulant. It produces increased mental and physical activity. It causes alertness. It increases the concentration and attention span. It produces the euphoria. Euphoria is false feeling of well-being. It increases the capacity to work. Meanwhile, it also increases the initiative with self-confidence. It postpones the fatigue and improves the physical performance temporarily, as seen in athletes. All these drugs made amphetamine a drug of dependence and abuse. High doses even produces confusion, delirium, hallucination. The effect may be reversed with overdosage. The next, it has a relationship with the respiratory system. The amphetamine stimulates the respiratory. It has a very interesting relationship with the appetite center present in the hypothalamus. So when amphetamine acts on the feeding center in the hypothalamus, amphetamine reduces the hunger and suppresses the appetite. Amphetamine is also a weak anticonvulsant, so we're soon going to use in the patients of epilepsy. So it has so many adverse effects as the CNS stimulant, so it causes restlessness, tremor, no sleep, insomnia, palpitations, anxiety, confusion, hallucination, and prolonged use even may cause psychosis. High doses may lead towards angina, delirium, arrhythmias, hypertension, acute psychosis, coma, and death due to convulsions. Amphetamine is a drug of dependence and is a psychological sort of dependence. Amphetamine has some uses like epilepsy, being anticonvulsant, appetite center suppressive, so it is being used in obesity. It is also being used in narcolepsy, attention deficit hyperactive disorders. Now I'm going to name few drugs that are actually vasopressor, beta-2 agonist, according to their mode of action. So vasopressor mean vasoconstrictor mean alpha agonist. metaraminol, methemphetamine, phenylephrine, methoxamine. Again, going to repeat metaraminol, methemphetamine, phenylephrine, and methoxamine. The next is nasal decongestant. Nasal decongestants have two types, orally and topically. Orally are ephedrine and pseudoephedrine. Topically, oxymetazoline, cyclometazoline, nafazoline, phenylephrine, and phentermine metaraminol. Commonly being used are ephedrine, pseudoephedrine, oxymetazoline, and xylometazoline. The next is selective beta-2 agonist or beta-2 stimulants, salbutamol, terbutaline, salmeterol, or cuprenaline. The next is anoretic agents. The drugs that suppresses the feeding center in the brain are amphetamine, fenfluramine, dexfenfluramine, mezindole, phenylpropanolamine. This was all about adrenergic agonists or adrenergic system. Now we are going to start adrenergic antagonists. Antagonists are the one that has affinity for the receptors but they does not have any intrinsic activity. They are more in action as they have more affinity, but they does not perform any action because they does not have intrinsic activity. So adrenergic antagonists would be those that are going to block all these receptors as we studied alpha 1, alpha 2, beta 1, beta 2, beta 3. It means they are going to block all those actions that these receptors are going to produce when adrenaline is going to act. So it is an antagonist, it just go and attach to that receptor with a certain affinity, but after attaching it does not produce any effect because it does not have any intrinsic activity. So it is just going to block those receptors and just going to prevent the action of those receptors. So we're going to just reverse those actions or going to oppose those actions. So in short, adrenergic blockers bind to the adrenergic receptors and prevent the action of adrenergic drugs. So they are going to block alpha 1 and alpha 2 receptors and those that blocks the beta 1, beta 2, beta 3 receptors. So we have divided adrenergic drugs into two main categories, alpha blockers and beta blockers. Alpha blockers include selective alpha 1, selective alpha 2, beta blockers cardiac selective, and beta 2 agonist, and beta 3 somehow. So actions of alpha blockers. The important action of alpha blocker is to prevent the alpha receptor stimulation. I'm going to revise where there were alpha receptor. Alpha receptor was firstly present on the vessel where it was causing vasoconstriction. Alpha 1 was present on liver where it was causing glycogenolysis. It was present on GIT. It was present on the sphincters of the bladder. So when it is going to prevent the contraction of the sphincters of the bladder, it means it is going to relax. So it is going to promote the urine voiding. When I say it does not relax the GIT, it may say that it causes the enhancement of GIT motility. When I say it is not going to cause glycogenolysis, mean it doesn't increase the blood glucose level. The first and the most important one is alpha 1 causes vasoconstriction. So when you are going to block this alpha 1 receptor, you are going to prevent the vasoconstriction. So when you are going to prevent the vasoconstriction, you are going to, like say, decrease the BP. Fine. So this effect is very important. The fact is blocked by alpha 1 blockers. They inhibit the vasoconstriction, leading to vasodilation. Therefore, there would be decrease in the blood pressure. And the fall in the blood pressure is opposed by baroreceptor reflexes, which tends to increase the heart rate and cardiac output. Allah subhanahu wa ta'ala has made our body a sensory system that sense that something is going wrong. So whenever there is a decrease in the BP, or blood pressure is going down, the baroreceptor reflexes activates and sense it, and they tends to normalize it, and they increase the heart rate reflexly, and they increase the cardiac output. So alpha 1 always causes vasodilation. They are going to decrease the BP. Along with it, there is increase in heart rate, mean tachycardia, and increase in the cardiac output, always whenever you're taking alpha blocker. But the second step, there are alpha 2 blockers. And on alpha 2, we said they are also present in the nerve terminals where they act as a decrease the release of non-adrenaline. So now alpha 2 are being blocked. They are not going to stop the release of non-adrenaline. So non-adrenaline tends to increase or synthesize and going to release. But meanwhile, alpha 1, alpha 2 are being blocked. So non-adrenaline is going to stimulate the beta 1, beta 2, and beta 3 receptors. They are going to promote those actions more efficiently. So alpha 2 blockage always enhances the release of noradrenaline, which stimulates the beta receptor. Beta 1 stimulation in the heart results in tachycardia, decreases the cardiac output. Selective alpha blockers results in hypertension, as selective alpha 2 increases the noradrenaline, so they causes hypertension. Then you have another action like constriction of pupils, nasal stuffiness to decrease the resistance to the flow of the urine. Adverse effects are partial hypertension, palpitation, nasal stuffiness, and constriction of the pupils, impaired ejaculations in male. The next comes is a classification of alpha blockers. Alpha blockers are classified into two main categories: non-selective. Non-selective means the drug is going to act both on alpha 1 and alpha 2 receptors. Selective means the drug is selective for either alpha 1 or either alpha 2 receptors. Phenoxybenzamine, mercatile, tolazone, phentolamine, chlorpromazine, alpha blocker, prazosin, trazodone, euhembane. Phenoxybenzamine, we are actually going to discuss a few about every drug, like phenoxybenzamine binds covalently to alpha receptors, causing irreversible blockage. Given intravenously, blood pressure gradually falls and is associated with the tachycardia. This action lasts for 3 to 4 days. The next is agitylclides, like agotamine, agitoxin, and the derivatives are competitive alpha antagonists. This blockage is of short duration. Next, we are going to study something about tolazone and phentolamine. They are competitive alpha blockers. They are also going to block 5-hydroxytryptamine receptors, means serotonin receptors. They stimulate the cat motility, they increase the secretions, and enhance they can cause vomiting, diarrhea, in addition to other effects of alpha blockers. The next one is prazosin. Prazosin is very important, as we are going to discuss every time when we are going to discuss pharma. Prazosin is a potent, highly selective alpha-1 blocker with 1,000 times greater affinity for alpha-1 receptors. Arterioles are dilated more than veins, resulting in hypertension. So there is no significant tachycardia, as this is purely alpha-1 blocker. So it is going to spare the alpha-2 receptors. So alpha-2 receptors are spared with no increase in the noradrenaline release. The first and the important adverse effect of prazosin is first dose phenomena. In first dose phenomena, what happens is when patient initially takes these doses, and in case if it may lead towards the decrease in the blood pressure, so the patient faces postural hypertension. So in order to avoid the first dose phenomena, patient should take this drug initially in less doses and should take on the night time at the bedtime to avoid this phenomenon. Dohembine is a selective alpha-2 blocker. There are few uses of alpha blockers like hypertension, pheochromocytoma, and if you can use the alpha blockers in peripheral diseases and congestive cardiac failures, like in benign prostate hypertrophy. What happens is in benign prostate hypertrophy, there's a hypertrophy of prostate in males due to some tumor. So what is going to happen is due to the hypertrophy of the prostate, the bladder is not able to urinate. So these drugs especially, they are going to help out in order to do urine voiding by causing the relaxation of the sphincters and promoting the contraction of the bladder muscles, so they're considered to be helpful in the patients of benign prostate hypertrophy. Thank you, students. Hope see you in the next lecture.